Hello, everyone. Welcome. So glad you're here. This one is a real good one. You picked a real good one. This is my friend Diana Smith. She has a dispelling bee for you all today while she dispels some myths. That was a good joke, right? How to facilitate conversations about pregnancy and SUD. So, our wonderful Diana Smith is going to take it away.
Such a jazzy introduction. Thanks, Ali. Good afternoon. I see some familiar faces out there and some new faces. My name is Diana Smith. I am a certified nurse midwife. I'm a public health professional, and I've worked with the Project Nurture team at Legacy Health as one of the clinicians there for about the last decade. I also do some statewide work, working with hospitals trying to improve the care for this population, pregnant people with substance use disorders, and I'm thrilled. I'm also a mother of two kids myself, and am in my early parenthood, so I relate with a lot of the stuff that folks are going through who I care for as well. And I don't have financial disclosures, but I always like to make some personal disclosures and say I'm not a person in recovery myself. I do have family who are. I have an older sister who was clean and sober during her pregnancy at the age of 19 and then struggled for years and years, so navigated with her sort of all of the systems of healthcare and DHS and all of that. And she is in long-term recovery, which is great. And I also have lost friends and family to fentanyl in the last 5 years, and that is totally devastating. Medical colleagues who have died, youth who have died, right? Just devastating impact. I don't think any of us are really that far from someone who is struggling. My hope today is to help you all kind of explore best practices and try some things out, model some things about how to talk about pregnancy and substance use. And with that, increase your comfort and your skills to talk about this topic, which I think for a lot of people feels like kind of difficult territory over there. And in some ways, it's so simple, and in other ways, it can be really challenging. And so we're going to just kind of sit in that space together. And at the end, we'll talk through some sort of topical things of is this true or not about substance use in pregnancy? And we'll have some time for Q&A also at the end. So I was actually out on maternity leave when this talk was designed, and I was assigned this topic. It's called Dispelling Myths, right? And I thought, wow, we could take this in a lot of directions, right? We could talk about, does fentanyl cause brain damage? Or, we're going to talk a little bit about, what about Suboxone versus Subutex in pregnancy? But I thought the biggest myth, really, in my experience, comes from this idea that it's all going to go badly, right? The assumption when you meet someone who is active in their use and they're pregnant of oh my gosh, this is a bird crashing into a windshield. How are we ever going to make ourselves move forward from this? Are they going to be willing to talk to me? All of those sort of misconceptions, assumptions, the emotions that come up as a healthcare provider of am I going to be able to help this person? Do I know how to do this? Are they going to trust me? Will they talk to me, right? And in my experience, there's some really foundational, fundamental communication strategies that you can use that just completely change the dynamic. And my experience is not that it's a total cluster. My experience is mostly if you approach people kindly and you're transparent and you give them information and you're humble and you listen, that you can work together, and it's this really incredible experience of getting to be a part of someone's journey in healing and process of change. So that's what we're going to talk about, is a lot about communication. So just setting the stage, I think when people are using substances and they find out they're pregnant, what I've heard from folks is that there is so much confusion about sort of where to begin. I have to contend with the fact that I'm pregnant right now. Maybe I want to be pregnant. Maybe I don't want to be pregnant. Maybe it's a surprise. Maybe I've been trying for this, right? There's a lot of emotion around that. And then also, I'm using is this okay? Like, am I hurting my unborn child already? Where can I go to get care? I don't really know. I think I should maybe be doing some of these things, or I don't know what I should be doing. Where do I go for care, right? And their baseline experience generally in interacting with healthcare, like I'm a midwife, I work in a clinic, is, and in the world, I would say, a lot of people's experience is that they're just judged on face value. They have internalized a lot of shame and guilt around their use. And then there's this added layer of like, oh my God, I'm still using and I'm pregnant, right? Like, how do I get out of this? So our work then is to be like radically counteract that, right? And like come with kindness and really think about like trauma prevention. Like, I don't want this person to, I don't know how this is gonna go today, but I don't want them to leave feeling like they can't come back. And I don't want them to leave feeling like hopeless or there's no services. So I'm going to start by just trying to counter this. And I want to share a story with you of a woman who came with me to CARE. And after I got to know her a little bit, she showed up in her 3rd trimester. She was pretty pregnant. We're like working on catching up on prenatal care. She shared that she had actually gone to get care in the 1st trimester of pregnancy. And the day that she went, and I'm aware that like this is true for many people. Like, people work very hard to get to that first appointment. Like, I gotta put all my stuff away. I gotta shower. I need to get myself together so that nobody can tell that I'm struggling, right? I need to smell good. I wanna be clean. When I walk in that door, I'm gonna try to hide this experience of what's going on because I don't know if they're going to be kind or receptive to me. And she had gone for prenatal care, and she had decided that she was gonna talk to the provider that she saw about her tobacco smoking and kind of see how they responded, right? And when she did, she disclosed in her first prenatal visit, like, well, I'm smoking cigarettes and I don't want to be smoking cigarettes. And the answer she got was, you really shouldn't be smoking when you're pregnant. That can hurt your baby. It's really bad for your placenta, right? I'm gonna have to, like, I really want you to stop. This is not a good thing that you're smoking. She was like, that's it. I'm not gonna talk to you about my other use, right? Like, this is not a safe place to get help. So it really shut her down, and she felt ashamed and defensive, and she didn't get any pregnancy care until she got a lot closer to the time that she was going to give birth, when like people realized, like, well, I'm going to have to go somewhere to have this baby, right? So for better or for worse, I gotta go. I need to go. So I think about like, how can we counter that shame and guilt? And I'm not advocating here for like oversharing, like you keep a professional boundary, but you have to show up with like sort of a spirit of mutuality and humanity to be like, work together. Like, we're gonna work together on this. I used to have something over my desk that helped me prevent burnout, which was like, don't work harder than your patient, right? Because you can, as a healthcare provider or a peer or anyone, just like try and try and try to fix things, and you're frustrated because the person on the other side isn't ready for that change. And so I always think I want to keep the door open. I'm willing to work hard with them, but I'm going to try to like match their steps and then help them take like one step further, right? And I think for people who are active in their use, when they walk in the door in a medical setting, it's like, gosh, she hasn't gotten any care. Why is she just showing up now? We're busy, right? All these things. And what I have learned from the people that I take care of is they are often working really, really, really hard to get themselves to that appointment on that day, right? Like, I've had people, I saw a woman 2 weeks ago who came for a prenatal visit who had her phone stolen. So she took transit, 2 levels of transit across town to her mom's house. She had to reestablish trust with her mom, and her mom didn't want her to stay in her house, so she agreed that she could camp in the backyard for a time. That would allow her to then use her mother's phone so that she could schedule a medical appointment. And she had heard about Project Nurture, right? So she decided she wanted to go there. She made her appointment, but she didn't get an appointment until like a week or 2 later. So her mom agreed that she could come back there on that day, that she would take care of her dog, and then we coordinated transportation for her to get from her mom's house in the suburbs to her appointment. And when she showed up to see me, she had done everything she could, hoping that on the day she came to this first appointment, I could get her admitted to the hospital to start on methadone, because she knew she needed to stop using fentanyl and she needed to get onto medication, that her baby was going to be born fairly soon, right? I couldn't coordinate that on that day, so we had to go through that. But I bring this up because it's people are doing, so we made a plan to do it the next week, right? Then she had to go home, go back to her mom's house, rearrange all of these things, right? It was not a small thing for her to show up for care. And she had to overcome a lot of barriers that I personally didn't have to overcome when I was going to a prenatal visit, right? So there's some great documents out there, and we have so many doulas, and we have so many peers, and so many people from different disciplines here who I think are probably here because you're great advocates for people in this population, or you work in this realm. But people have rights, and in the medical establishment, we sort of sometimes forget this. We feel this weight of obligation to help people be healthy. And we forget that our patients actually have a choice about where they get care, whether they come to get care or not. They have a choice to decide whether they accept the care that we recommend to them, right? They have a right to decline procedures. They have a right to decline drug tests. They have a right, and there are good reasons why they might choose not to just right off the bat say yes to things. They have a right to support during labor, including from a doula support person, but also people of their choosing who are in their support system when they're giving birth. They have a right to breastfeed. Anything that they're doing medically, they have a right to have a provider come and in their language or with interpreter services to explain to them the risks of the care that we're recommending to them, the risks of not accepting the care, and explore sort of the alternatives, right? We have an obligation to help them understand their options. Substance use disorder is probably really also under-recognized as a medical disability. People with medical disabilities have a lot of rights to have advocacy and support as they're navigating the system that just, in reality, just doesn't exist. Most people don't have those services lined up. And at very baseline, right to being treated with dignity and respect and to file complaints against the medical establishment or anywhere if they have concerns about the care that they've received, that they have been experiencing discrimination. So we have a professional obligation working in this field to treat people with respect and dignity, and not to discriminate against them based on their health condition that is protected by law under the American for Disabilities Act, right? So now on to some positive skills and tools. I was thinking about this, and one area that I've worked in a lot as a midwife before I got into doing substance use disorder treatment is working with community birth transfers, so folks who have decided to give birth outside the hospital that then come to the hospital for care. And what I have found is that if you, in your first encounter with someone when they're transferring to the hospital, if you just pull up a stool and you actually sit down, and this is hard for medical people to do because we're busy and we have multiple patients, but I'm telling you, if you do this, if you take this script and you do this in your first encounter with someone, every one of your interactions with them going forward is going to be completely transformed. You sit down and you say, I'm really glad you're here. I know this wasn't part of your plan, right, for someone who was going to give birth at home. I hope that we can work together to give you the care that you deserve and the best care. How are you doing? How are you feeling right now? How are you doing today? Just doing that and doing some level setting is huge. Now, we should treat everyone like they've experienced trauma, because most people have. But particularly for people who are pregnant with use disorders, we need to be thoughtful about trauma triggers. And I want to prevent someone from experiencing any new trauma or trigger while we're having an interaction. So I'm going to set up the physical space. I'm going to, first off, I'm going to ask them how they're doing, and I'm going to say, you're welcome to sit wherever you want. The first thing we're going to do is talk, right? Again, anxiety drops down, right? I'm not gonna sit in a position where I have between them and the exit or where I'm blocking their line of sight, and I'm gonna give them options about where they wanna sit. I often arrive late to appointments as a provider because I'm running behind in clinic. My patients sometimes also arrive late. I very often walk into a room and I say, I am so sorry you've been waiting for me, right? Sometimes it's the other way around where I'm waiting for the patient, but more often than not, they're waiting for me for a time. And so I acknowledge that. And I ask them, like, how much time do you have? And I respect that limit because if you're working with someone with a use disorder, there's a few things going on there, right? They might not feel safe and not want to stay. They might have come for one reason. Like oftentimes people are showing up thinking they're going to get this support, and I'm thinking that I'm going to provide them with this, and we have to kind of navigate that. And then the other thing is, like, fentanyl wears off. Like, if you're smoking fentanyl, you are within 30 minutes to an hour of having smoked last, you're gonna start feeling ill. You're gonna start sweating, it's gonna be really uncomfortable. I'm a breastfeeding mom. I have this experience in my professional space of like trying to monitor what's going on with my body while also like doing my job or interacting with someone, and I'm like, oh, I'm getting engorged and I'm getting sweaty and it's getting hard for me to focus, and like I gotta get out of here because like, well, I want to do this visit, what I need to do is go pump, right? Like at this first conference I was like, I would love to talk with you, but I gotta go, right? And so people who are in their use, even if they're not wanting to be in that state, they are despairing for having gotten into this situation where they can't feel well if they're not smoking every hour or using. But I actually, in a first visit, when someone's active in their use, I give them permission to leave. I'm like, I don't have to be explicit about it, but I'm like, if you need to step outside for a time, like if the visit gets overwhelming and you just need a break, you can step out and come back when you're ready, or we could schedule you back for another day, right? Because otherwise they're gonna maybe not be present or be able to function during that visit. And I know that feels a little uncomfortable for people sometimes, because it's like, am I telling her to go use? It's like, well, that's where we're at today, right? She hasn't gotten treatment, she's not on medication. She's gonna have to continue using until she can get connected with those services and stable so that she's feeling well enough that then she can show up in a different way too. I turn the medical chart around so that like people can see their chart, right? And I spend a good bit of time like orienting people to their chart. I tell them like, this is the tools that healthcare providers use to kind of like document the visit so that next time you come, we can remember what we talked about. Your chart here at Legacy connects to your chart at OHSU, connects to your chart at Adventist, connects here, right? So that it's not like this weird thing of like, how does she know that I was in the ED at Kaiser or that I used to live in California, right? Immediately you're like, oh no. I mean, I think that when I go to the doctor, I'm like, oh no, they might have read about what I was doing 10 years ago. Shoot. So I think that also lowers people's anxiety. And then it also puts them in charge of like, part of my goal in the visit is like, I need to do a history and physical. Like, I wanna get to know you, I wanna hear what's going on with your health, and like, this is the tool that I have. So let's look at it together. Like, this stuff is in here, is this still relevant to your life these days, or how are you doing with your asthma, et cetera. And then asking people if they wanna include support people. You know, this works both ways. Sometimes they're like, no, I need him to go sit in the waiting room, or like my mom to leave so that we can have this conversation. And other times it's like, yeah, I don't want to talk about my health history with you sitting alone, right? So I'm super upfront with people. I say, you know, our visit today is, you're scheduled for this. I want to know what's important to you to cover today. I ask a lot of personal questions about your health background, about sexual health, about pregnancy health, about substance use health, right? And my intent is to get to know you and to be able to provide you good health care. But you don't have to talk to me about any of this. We've only just met. I hope I gain your trust, but if it's not today, that's okay, right? Like you have the right to say, I don't want to talk about this today. And that's another tool that I find people usually are a lot more actually comfortable actually talking to you if they don't feel like there's this power dynamic of like any question I ask, you're obligated to tell me, right? And you gotta just kind of like breathe and check yourself, you know, like, how am I feeling? I'm still feeling kind of nervous up here. Am I talking fast? You know, is my face like corresponding with what we're talking about, or am I actually like thinking about how I'm running behind, right? Like what's going on that this person is gonna pick up on? And I think a lot of the work that I do, we're helping other healthcare providers improve their care for this population, honestly, is helping healthcare providers process their own emotions around the experience that they have when they're taking care of patients, because medical training and nursing training and the systems that we work within aren't very trauma-informed, and they don't allow nurses and doctors and midwives on a busy day at work to check in with themselves very much, and then they are in turn projecting their assumptions or bias or their busyness or their fatigue or their burnout on the people that they're taking care of. So that's another thing, if you are on the other side of it receiving care, to remind yourself, like, this really might not be about me, right? Like, healthcare providers have a lot of their own challenges that they're navigating, and it might not be about you. It might be about the busy schedule or like the pressure of the job or a hard outcome that another patient had on that day that they're bringing with them to this encounter. You know, more of the same, be respectful, ask permission to talk about things, give people permission to not talk about things. I use a lot of normalizing statements, and I think this is really helpful. And I can do this super honestly. I can say, every day I come to work, like, I take care of people who are using drugs when they find out that they're pregnant. Or, we care for a lot of families here who are impacted by substance use. You've come to the right place, right? Like, this is not just about you and your own failing. This is a reality of what's happening for people, and I'm here for it. Unconditional positive regard is this like really powerful thing. So there's a lot of research into this in psychology and mental health, which is to say, if someone in your family, someone close to you, or your healthcare provider, or a teacher, someone who you respect, shows you kindness and mirrors for you your strengths and treats you with unconditional positive regard, like kindness and love, it actually changes the way that you think about yourself, and it impacts your self-esteem. And that in turn is necessary. You have to have a positive sense of self and agency to be able to take that step to create change in your life, right? So a lot of times I just pause. People will be sharing things and I say, like, I can hear that you really care about your children, right? Like, it really took a lot for you to get here today. I get like shivers as I'm saying it because I have this experience of people will cry, and you are inviting like some real connection when you do this, but that is sort of like where the healing happens for people. You ask strength-based questions. So like for someone who's using, most people who are using have had times where they've stopped using, not everyone, but like talking to them about like, what's been helpful to you in the past? Like, did methadone or buprenorphine work for you? Or what do you feel like would be helpful? Like, you know yourself, even if you haven't been in this situation, you've lived your life and you've had stress, like what would be helpful for you? And really framing it in positive, like, let's figure out together what the next thing forward would be. And I talked about this a little bit already, but like providing context for your questions, I feel like it's super normal in medicine or nursing to like walk into the room and be like, hi, welcome to the hospital. So are you safe at home? Have you been using drugs? Any blood or mucus or anything coming out of your vagina today, right? Like that is our day-to-day, but that is not everybody's day-to-day. So I always am like, I'm a midwife. I ask lots of personal questions. I see so many vaginas in a day that I'm sure yours is special, but I'm not going to remember it tomorrow, right? The reason that I'm asking is, like, our goal today is, like, we want to figure out if you're in labor. So I'm going to ask some questions about your body, right? I'd love to connect you to someone, or, like, start you on some medication if you're needing that to manage your withdrawal symptoms. So I'm going to ask you, like, what drug are you using? How often are you using? Are you injecting it? Are you snorting it? Are you swallowing it, right? And so these are, I see my OB colleagues out there and I see treatment colleagues and things. Some of us are super comfortable talking about vaginal discharge, but asking somebody like, when did you last shoot up? And how much heroin are you using? Or like, do you have a clean pipe to smoke your heroin, or are you sharing needles, right? Like, those questions for us are super uncomfortable. And then there's folks in the treatment world that are like super comfortable with syringe exchange services, or being like, let's just get your, like, I know you're not ready to stop using, but let's like clean your skin and get you like a wound care kit, right? Or like, do you have Narcan? Do you know how to use your Narcan? You know, people will be like, oh yeah, I overdosed last week, or I just Narcaned my friend, right? Like, that's like very much in the vernacular of use and treatment. But if you're talking about like a baby and breastfeeding, or like a nipple sore or a vaginal discharge, those folks are gonna be like, whoa, right? So part of what we're doing is we're trying to come together as a community and say, oh cool, you're comfortable talking about this, I can help you learn about how to talk about XYZ, or like, that's not my area of expertise, but I know someone cool who you can talk to about that, right? Let's call her together. So transparency also really builds trust. Like, there are two scenarios I want to talk about here, okay? One is like, I've been seeing someone for a while, we're developing rapport, and then, you know, she's doing some treatment in my clinic, and she's doing urine drug tests, and I get a result of a urine drug test, and like, she told me she wasn't using, and here's the drug test that says, oh, there's fentanyl in your urine, or whatever, right? And I, as a healthcare provider, I ordered this test, I talked to her about it, she consented to give the urine, she's a part of our treatment program. I can't just be like, okay, clear that result out. Like, whenever I get like a low iron result, or a positive pregnancy test, or a positive urine drug screen that says something that is unanticipated, my job is to call that person and talk about it, right? And it can feel like a difficult conversation, because people will feel like, well, she lied to me, she said she wasn't using, and now this is showing that she was using. Or maybe she wasn't using and this is a false positive, right? Because that can happen too. I don't have the confirmation test back yet, but I know that she's gonna get my health message and see that it came up back positive, and I'm worried, like, she's never gonna come back and see me if she's worried now that we think that she's using and she wasn't, right? I don't know which it is. I don't know if it's a false positive. I don't know if it's fentanyl that is still there from her last use 2 weeks ago that she didn't know would show up. I don't know if maybe she has had a return to use and she didn't feel comfortable talking about it, but she's wanting help, and so she left this urine drug screen, kind of like, a lot of people have told me that, like, I've left urines hoping to get caught, right? So that somebody would help me. And then no one ever even like called me about the results, or, so we just have to be honest and transparent. It's the same thing, you just call them and you say, you know, I just got this result back, like, is now a good time to talk about it? Do you want to come into the clinic and talk about it? Do you want to talk about it over the phone? And I just disclose, like, this is your urine test, this is what it came back as, how is that landing with you? How are you doing with this result? And then we have a conversation, like, is this a false positive? I honestly don't care if people, like, I'm not trying to catch people lying, I'm trying to get them health care if they need health care, right? So I would explore this with them, like, there is fentanyl stays in your system for up to a month after you stop using, sometimes even longer, depending on how long you've been using fentanyl, because it stores in your fatty tissue like lots of other medications do, right? So it's gonna show up that way. And it makes it tricky to interpret as a healthcare provider. So I have to be honest about that. I don't know if this is from yesterday. I don't know if this is from a month ago, right? The other thing that really comes up is circumstances, and I want to talk about this a little more, where it's actually not that often in my practice that we have to make a DHS report, because we do safety planning with people and we are able to connect them to treatment services, and we have a nuanced understanding that like using a substance when you're pregnant is not the same as child abuse and neglect, right? Most people are using most pregnancies are unplanned, and most people are using some sort of a substance, legal or not, when they find out they're pregnant. Or like Accutane for their acne or their wrinkles, right? That could potentially harm their baby, or something else that they're using for their body that they didn't know they were pregnant and then they find out. So like just using, many of those people are gonna be able to just stop using. Some of them are not. And those are the folks who have a substance use disorder. They have physical dependence, they need the supportive counseling, right? They need treatment for their health condition in order to stop using. So that's one thing we have to tease out, right? Substance use and child neglect and abuse are not the same thing. But there are circumstances where a client of mine has a return to use, and their use is creating circumstances where a child who's in the home, like an older child or a baby after they're born, questions come up about whether they're gonna be able to parent safely and they're keeping their child safe because of some of the stuff that's going on around their use. And if I become aware of that, I do have an obligation as a healthcare provider to report to child welfare. And I don't want to do that in a way that's going to like break my relationship with this person so that they're never going to come back for care. And I think the way you use these skills up front, so that if you are the person on this day that has to have this challenging conversation and work with this family around this impactful event of like use impacting their life and help them figure out what to do, you have the relationship to do that, right? And I'm always gonna call that person first and say, hey, I got this drug test back and it shows fentanyl's in here. How are you doing? Like, I'm worried about you. Have you had a return to use? Do you wanna come in? We can talk about treatment services, you know, and I'm gonna assess the situation more. And I'm gonna start by saying, I wanna talk with you and assess it and figure out what to do together. And then if we are going to need to make a report to child welfare, I wanna do that together. I wanna make sure you're there and we're having the conversation together, because I'm not gonna go around you and just do a report. We're gonna talk to them together. We're gonna also like plan, like what are the things we can ask from child welfare? Like, I'm struggling, I have my kid with me, but I'm needing treatment. Can you help me get treatment? I'm gonna need transportation to my, like really thinking again in that strength-based way of like, how can we use the system to help people? Like they're freaked out by child welfare. Sometimes we can be like, well, if they come out, let's get you set up with XYZ and the supports that are available to get you in a spot where you can be parenting your kid if that's what you wanna be doing, right? You also want to just like not overpromise on any given day, and in the spirit of reciprocity, like ask for feedback about how things are going. I think I got off a little bit on a tangent there on this slide, but here we go. So you're gonna think about like choosing the right time and setting. Sometimes one person on the team knows the client better. Like I work with a group of midwives. If I'm getting the test result and I don't know this person, but the midwife who had the visit with them is there, I'm gonna ask her to be the one to call, because relationship is really, really big, and wherever you can, like building in a thread of continuity of relationship for these folks can be really valuable. So, someone comes back to triage, if the nurse who met them last week and took care of them is there, getting that person back into the room to continue that conversation is gonna be easier than maybe having someone they don't know having to go through this whole process again. Ask people if they wanna have support. Like, we need to talk about DHS reporting. I imagine it's going to be kind of stressful. Do you want to ask somebody to come and be here with you? Like, what can I do to make this? It's the same thing I say, honestly, before I place a speculum in someone's vagina. Nobody likes to do this, right? What can I do to make this as comfortable as possible for you, right? Is there something you want me to know that will make this go as well as we can hope, given that it's not going to be a comfortable thing? And with the transparency and sort of helping people do parallel planning in advance, like, okay, having plans, like talking through things like, okay, and I do this with birth too. I see a lot of parallels between like birth and caring for people with substance use disorders. And then when they're pregnant, we get to do both, right? So I'm hearing you. You really don't want to have an epidural, right? Or you really don't want to experience pain and you absolutely want to have an epidural. Okay, neither you nor I today know how your labor and birth is going to go. We don't know how the conversation with DHS is going to go, right, or what's going to happen next. But what we can plan for is support and plan B, right? So you want to approach labor without medication? Let's do that. I want to make sure you know about the medicines that are available if you decide you need to change your plan, so you're not hearing about it for the first time, right? Similarly, let's talk about what might happen, like what are your risk factors for having DHS come and talk with you when you go to the hospital to give birth? What are your protective factors? Like what are the things that we can build in that are gonna help reduce your chance of having child welfare involvement, reduce your chance of like needing an epidural? How can we keep labor normal and keep you well supported? But then if it does happen that you need to change plans and get an epidural, that's okay too. How can we support you when that happens, right? Like these are possibilities on your pathway here as a birthing person with substance use disorder. That's called parallel planning. Oftentimes people are not able yet to be like, okay, I'm going to residential treatment, right? Because that sounds like so scary and over there. And people feel the same way about a C-section. There is no way in hell I'm gonna have a C-section, right? I'm like, well, you're gonna give birth this month, and there's like a 1 in 3 chance that you might have a C-section. So, you know, you haven't had treatment yet, and you're gonna have a baby. There's a possibility. I don't know all the circumstances of your life and how this is gonna play out. Like, I'm with you. Maybe you wanna try to stop using at home and would do it this way, but there's a possibility that when you have your baby, that DHS is gonna come and talk with you. And so if that happens, let's check out what the treatment centers are so that you know in advance sort of what your options are. Let's think about where your older kids might go if you need to go to treatment for a time, right? And sort of doing that parallel planning sort of, again, helps them begin to prepare and move in that direction. Cultural awareness is super important. I actually forgot to say at the beginning of my presentation, I'm trying to like self-disclose some things myself as a way of like modeling that for other people. Like my pronouns are she, her, I'm a cisgendered female. I was raised Buddhist, which is like something about me that I recognize impacts who I am and how I do this work. Also, you know, having family in recovery and those things. Similarly, like we can have snap judgments of people, but we don't know unless we ask. So it's important to ask people, both around pregnancy and around treatment and substance use. People have a lot of different belief systems about how they want to approach it, what recovery might be look like for them in their community, whether medication is something that they're willing to use while they're pregnant or use to treat their substance use disorder. So I just ask open-ended questions like, do you have any personal beliefs, religious beliefs, cultural beliefs that impact your health that you'd like me to know about? And when I do ask that question, it's like some really cool stuff comes up that helps me better understand who this person is and like align their care with what is actually gonna work for them. Has anybody taken motivational interviewing courses? Yeah. I think this is something that like I go back and I'm like, I need to learn this again, and I need to learn this again, because it's not super easy, and it's really different than how we're trained in nursing or medicine. But essentially, it's like, how do you help people move through their process towards change? And I always remember this visual at my first motivational interviewing course, which was a big mountain, like picture Mount Hood, right? And you meet somebody and we're over here, and the tip of the mountain is the inflection point where they're ready to make change. And to get there to that inflection point, we have to climb this mountain, right? One step at a time, one foot in front of the other. Sometimes you slip and you slide back, and then you have to keep climbing. I never liked that when I first learned it, because I feel like in healthcare what we want is like you show up with a problem and we tell you this is the thing that you do to fix it, and you want them to be here on that day, right? And say yes to like treatment and yes to the medication, and then be ready for the change process. But the reality is like change is pretty incremental and it's not always linear. So if you haven't taken a course, I think it's a really great skill. There's a great book to read on, and it's been helpful in working with this population. I also think about substance use disorders as a chronic health condition. I have diabetes, people in my family have high blood pressure, folks have different mental health conditions, right? And when you think of it as a health condition, it's like, okay, this is probably chronic, it might be lifelong. You have some genetic factors maybe in your family that maybe put you at more risk of developing a health condition, right? And maybe when you're young, it's not impacting you so much, but as your life goes on and the condition evolves, you're gonna start having more secondary health effects. Most people with any chronic health condition are gonna need a lot of care when they're in an acute episode of their disease, right? That might be medication, it might be social support, it might be some time at the hospital or some time in treatment. And as they get those interventions and their health improves, then they can step down to the next level of care. This is called like the continuum of care. So you start with a specialist and then you go back to your primary care provider, right? But then you're doing great. You're like, okay, awesome, I made progress, my meds are working for me, getting going, and then my sister gets in a car accident and I have to go help take care of my niece and nephew for a while she's in the hospital, and this is like stressful. And suddenly, like, I'm diabetic and I eat pretty well, but I'm like grabbing what I can because I don't have time right now, or I'm stressed and I crave sugar and da-da-da-da, right? And then hopefully at some point I can like go, oh gosh, I got a little off course, I need to steer my boat back over here, go see my endocrinologist and like get my labs done and those things, get my medication renewed, and then, you know, try to get back to that place where I'm feeling more stable. Like, that's kind of what we expect in the life course for someone with a use disorder. It's not like there's one day where like, ping, and then it's like recovery forever. Like, I would hope that for people, or for any diabetic or someone with high blood pressure to like get to avoid all that downstream stuff. But the reality is that people are probably gonna weave in and out of it, and so they need to be able to access care and slide up and down through this continuum of care when they need it. So you can see, you know, there's like active use, there's harm reduction where they're still using, but you're talking about like how to use more safely, not using alone, having naloxone, cleaning your skin so you're not getting secondary infections. A lot of the impact of substance use on people's bodies, and this includes during pregnancy, is not actually the effect of the drug. It's the effect of like infectious disease that might come with their pattern of use, or the hardship and the stress of poverty that comes, right? Or the nutrition imbalance from like you were up on meth for a couple days and you're not eating, so you're not like gaining weight. It's not actually like there are things, meth can raise your blood pressure, but it's not, it's more about like if you can do harm reduction, you're doing a lot to improve their health and the health of the pregnancy, even if they're continuing to use. And then there's treatment, and then folks talk about treatment and recovery being two different things, right? Like cessation of use and being in recovery are not always the same. There's a continuum there too, right? And it has to do with other spiritual things, getting your life in order, reconciliation, those things for some folks. So you're gonna offer this like whole spectrum and be like, where are you at? Like, where do you want to start today? And how can we help you move towards health? Pregnancy, whether you have a use disorder or not, like sometimes is planned. We ask this question, like, is this a planned pregnancy? I think this is a misnomer for most people. Like, people tend to have all kinds of ideas or visions for themselves in their life about whether they want to have a family or not that may or may not be aligned with their current reality. And there's this great tool that's called One Key Question, and this is a question that anyone can ask, regardless of the setting that you're working in, which is just to ask somebody, a man, a woman, anyone on the gender spectrum, like, are you wanting to have a child in the next year? Are you thinking about having a kid? Are you wanting to become pregnant? And it opens up a conversation where you come to understand like where their thinking is at. I think there's a big misconception that folks who are using don't want to have kids or that the pregnancy was accidental. And that is often not the case. Very often people really actually want to parent and have that child and they want to build a family. They may have had a child removed and then they're like, I'm gonna have another baby and try again. There's also like, I got a bunch of services when I got pregnant and then they all fell away, right? Like maybe this is a path for me to get well and get health care. So I don't think we can make assumptions about sort of where people are at, and we really have to ask them, and then that, again, gives us opportunities to tailor care of like, well, you're not wanting to be pregnant. Can I refer you over to Project Nurture to get some contraception? Or, let's explore options surrounding parenting, adoption, abortion, right? All options. And that somebody is actively using doesn't mean they don't want to parent, and that they're in the recovery doesn't mean they want to continue a pregnancy, right? We don't know unless we ask. So I never learned about reflective supervision in my nursing training. I like to think that I'm like, have a badge of an honorary social worker because I've like learned a lot from my social work colleagues, but they have this thing called reflective supervision. Has anybody had reflective supervision? It's supposed to be built in for healthcare, for like mental health professionals, social workers, peers, where like you have you acknowledge that our jobs are hard. We can have vicarious trauma. We also bring our own biases to our work, right? And if we don't take time and acknowledge that and reflect on it and process it, then we become a liability to the person we're taking care of, because then our assumptions and our judgments or our own burnout are going to influence our interaction. So what a practice. I've started just doing this for myself because it's like not built into my work environment, but like sometimes I'll leave clinic and I'll be like, I feel really burnt out, right? Like I gotta go take care of my kids. I want a drink now, or I want ice cream. And instead I'm like, okay, let's check in. What happened today? How was I feeling when I got to work this morning? What came up for me when I was in that visit with that patient, Sometimes it's about my own birth or my own life experience that got triggered and came up. Other times it's about something they said that I didn't understand or I didn't feel like I could help them, right? What assumptions did I make? What did I bring to that interaction that maybe influenced this interaction that I had with them? How did I feel before I saw them? How am I feeling now? And just doing a little bit of this self-inquiry, like you process it and it moves out. Like ideally you might be doing this with like a peer, a colleague, or like someone a counselor, right, who's there to support you in this process, but we have to do it regularly. Otherwise, like, we get burned out and we stop providing care in the way that we want to. And then lastly, I thought I would share one bit of learning that's about, I think of anyone working in this domain being agents for change and patient advocates and system advocates. And the ways that, what the research tells us about how to communicate and advocate and do work for people with substance use disorders who are pregnant is that the public and policymakers and systems are most receptive when you share some personal stories. So you like tie it really to like personal experience. And then we focus on how can we change like these structural barriers that are impacting people's health, right? We have to get out of this thing about thinking about the patient as a victim or a criminal or not following our instructions, and really think about the systems that we work within and how we can help change them and help people move forward. Here are some more content-based questions that people ask. So every week in our Project Nurture groups, we have 10 minutes at the end. We do this thing called Questions for the Midwives, and that's where pregnant people with use disorders or early parenting can ask us questions. And I love this because it's a two-way relationship builder. And these are some questions that I get pretty often, either from healthcare providers or from pregnant people. Buprenorphine and methadone are both safe to use while you're pregnant. They are the recommended treatment for people with opioid use disorder. Buprenorphine is not approved by the FDA, the Federal Drug Administration, for use during pregnancy, which means they haven't done these like large research studies that are proving like safety, essentially. That said, what we're not comparing someone who is like completely healthy without a use disorder who doesn't need medication to the effects of buprenorphine. What we're thinking about is buprenorphine as an alternative to continuing to use the other substance, right? And so there is good safety demonstrated through caring for people and for more than a decade, people taking buprenorphine and their babies, that demonstrates and that it is low risk and safe to use. And also that it's going to help eliminate the likelihood that they're going to return to use, and thus avoid the impact on health of continued use for this person, right? It's going to help them in their recovery journey. Naloxone in buprenorphine in the dual combination is not absorbed by the body when it's taken orally. So you can use buprenorphine monotherapy, or you could use buprenorphine and naloxone, and they are going to be processed in the same way by the person's body. The naloxone was put in there as a diversion control strategy so that the tablet, theoretically, if somebody was trying to use it in another way, like crushing it and injecting it, it would not work. The opioid effect wouldn't be there. But it's not actually absorbed. It's not bioavailable when you take it as prescribed. So either one is fine. Methadone, a lot of folks using fentanyl have developed like significant opioid dependence, and there was like a real sea change when fentanyl hit the streets of being like, most people are choosing buprenorphine as their treatment medication to needing to use methadone more for folks, because the transition from fentanyl onto buprenorphine can be challenging just because of the pharmacology of the medication. So methadone is a great option. Buprenorphine is not off the table, though. There are ways that we are learning and we have learned to help people transition onto buprenorphine who are using fentanyl by doing these like microdose slow step inductions, or by helping them transition onto methadone first and then transitioning over to buprenorphine. But it is more complicated than it was when heroin was the dominant substance of use, and so just know that the treatment communities are like really having to try to learn and grow and find new ways to do this as the drug supply has changed as well. You can continue taking your treatment medications, buprenorphine or methadone, if you come to have a baby and have your pain managed. You do not need to stop those medications. There are medications like naltrexone, which do fully block opioid receptors, that don't work well for people needing pain management. But the way that we proceed with, for folks who are taking buprenorphine or methadone, which is the majority of treatment medications, is to continue their treatment medication and also treat their pain, right? Childbirth can be painful, and people need pain management in addition to that, and we can do that. We encourage people to breastfeed if they're on treatment medications. It actually lessens symptoms for their baby as they transition to being out. Tubal ligations and vasectomies should not be considered reversible. Lots of people ask me, but like you can turn that around, right? It's considered a permanent sterilization procedure, and people need to be well informed about that if they're making the decision to do that. People also get pregnant very soon after having a baby, even if they haven't returned to cycling, or sometimes when someone's in a period of active use, their menstruation is impacted. And the pregnancy that's another reason why we have a lot of unplanned pregnancies in this population, is people don't know that since they haven't been cycling that they are still fertile and could get pregnant. The DSM-5, which is like the Bible of mental health for healthcare providers, says that people need to be in a period of remission and not actively substance using in order to get a good mental health diagnosis. So like in an ideal world, yeah, you would have time where you're not using, and then we could clarify, like, is this depression or bipolar, or da-da-da. But the reality is that people need mental health treatment concurrent with their substance use if they're gonna have a chance to get out of it. And we cannot afford to wait until everyone's deep in recovery before giving them mental health services. And I talked a little bit already about the requirement to report. And if there's one takeaway, I just want you to tease out in your brain this thing of like, drug use does not equate child neglect and abuse, right? It's so much more of a nuanced conversation that we have to have and explore with people to understand how to help them be set up for a safe and healthy parenting if that's what they want to do. So thank you so much for your time and for listening. I'm going to leave this up here, and we can do we have time for Q&A? We don't. It's the end.
It's all my fault because of the recorder. We needed a couple of...
It's okay. I just, for a moment, would invite everybody to just like read through these questions and take a moment and reflect for yourself, like what brought you here today, whether it was in this presentation or one of the others. Is there something that you've learned that you're hoping to bring with you out into your practice in the world? And just do this practice of checking in with yourself. Like, what is my part in this, right? What assumptions am I bringing that are impacting the care? Or what does this bring up for me emotionally? And thank you so much.